I always have this thing of being busy during public holidays. That's why I can't forget that date. As I was settling in, I realized that we're already at the beginning of meningitis season, and there was no meningitis preparedness and response plan on ground. So immediately after the New Year holidays, I assembled my local team and partners, and within 2 weeks, we came up with a meningitis plan. So at that period, there was also heightened sensitization of the Lassa fever in the country. We did a risk assessment in the state. Kebbi State hadn't reported any Lassa fever case before as at then. So we decided to also include Lassa fever among the, together with CSM, and we came up with a joint preparedness and response plan. So that plan was submitted to the State Ministry of Health in the 3rd week of January. That very week, I got a very disturbing call from the Federal Medical Center in Birnin Kebbi that a patient presented with signs and symptoms suggestive of Lassa fever. I was like, no. I was in denial. I double verified. If there's a word like triple verified, I had to do that just so that I'm sure we're actually dealing with a suspected case. At the 4th week of January, the ministry approved our joint CSM and Lassa fever plans and submitted it to His Excellency for approval. Then on the 5th of February, we received the result of the sample that was collected, and it was confirmed that we had a Lassa fever positive case in the state. So I immediately informed the State Ministry of Health that the plan we submitted to His Excellency needs to be expedited, because now we're not only going to prepare, we'll have to mix response together with preparedness. Fortunately, I met a brand new public health emergency operations center in the state, just about 1 month old, which was established by the Nigeria Center for Disease Control. So it's just a public health EOC is a physical structure. To make it short, it is a structure that is used to coordinate, manage outbreaks, to save time and resources. So there's what is called an incident management system with different pillars that helps to coordinate and respond to outbreaks. So we developed our plans based on this structure. So even at the point of developing the plans, we had already assigned roles to individuals. Okay, for coordination, this is the pillar lead for coordination. For surveillance, this is the pillar lead, and these are the activities you are required to do. For risk communication, this is the pillar lead. Case management, so we had different pillar leads with roles already assigned, and we developed our plans along those roles. So the presence of those plans now helped us to respond adequately to the outbreak. So it was an intersectoral collaboration together with ministries of animal health. In Kebbi State, we have Ministry of Agriculture separate from Ministry of Animal Health and Husbandry. So initially we started with the Ministry of Animal Health and Husbandry, and because the area where the index case was located was around the Army Barracks and the Nigerian Prison Services, we also had to induct them into the response. So in the course of investigating and responding to the index case, we enlisted about 56 contacts. So we had to now assemble these contacts. So you have to understand, this is the first time that we're having this Lassa fever outbreak in Kebbi State. There was a lot of anxiety, not just among the general community, but even among the healthcare workers. And most of these contacts were people that were working in the Federal Medical Center, which I think was fortunate for us. So we assembled them so that we could categorize them and do the appropriate things. Through NCDC, we were able to get PPEs and other materials we needed. And we also had to procure thermometers and other drugs for supportive management for the patient. So the thermometers were used for the contact tracing. We trained all the contacts on how to use these thermometers, and we categorized them. We also assigned individuals from our unit to monitor each of these contacts. So at the onset, ideally, besides the calling, we're also actually expected to visit these contacts just so we do the proper thing. But being a new outbreak, it was a new experience for everybody that was involved. So for the index case and the contacts, we used only the phone calls to track the contacts. And it was sensitive enough, we picked 2 additional cases via the contact tracing. So some of the things we realized then was that you are restricting an individual's movement because he was kept in an isolation center, and we had to a caregiver had to be around to take care of 1 or 2 needs of the patients. So we selected someone that was already exposed to the case to do that role. So we realized that there was need for essential things like feeding for this patient. So we were able to provide some financial stipends for those first 3 cases. So as we were responding to that index case and the 2 contacts, we were also implementing some of the preparedness aspects of that plan, because it came before we could even implement the preparedness plan. So we had risk communication activities in all 21 local government areas of the state. Each LGA has a social mobilization team, which included the LGA DSNO, the LGA health educator, and someone from Ministry of Information and also National Orientation Agency. So as usual, preparing for new diseases, in this case, Lassa fever in Kebbi State, will always come with challenges, or even define your initial incident action plan. So we had the challenge of having a suitable treatment center for these cases. In our plan, identifying a treatment center was kind of a medium to long-term thing, because based on our risk assessment, we didn't expect that we'll have a case. So we just had to make do with what we had as at then. And also something we didn't even factor in the plan was environmental sanitation. Where the index case was residing was exactly opposite a huge refuse dump. You know, rats and everything there. So it was a real challenge evacuating that place, because evacuating it was not only the solution, you also had to provide an alternative for people staying in those areas to now dump refuse, because they will still generate refuse at the end of the day. And then we also had issues regarding healthcare worker infection, and also issues regarding incentives for healthcare workers managing these cases. So after the first 3 cases, we were implementing the preparedness component of the plan. About a month later, again, we had another confirmed case in the state, who unfortunately died within hours of arrival at the Federal Medical Center. So by this time, we had improved on the initial response to the first 3 cases. Our contact tracing was now the documentation was now better. Initially, because it was a sudden thing, we used Excel sheets. We just call in, fill in what we need on the Excel sheet. But this time around, for each case, we came up with contact tracing forms, and some of them were actually being visited. Then based on our experience on feeding those first 3 initial cases, we realized that giving those financial stipends wasn't really effective because that particular caregiver was almost always in the hospital. So we had to get the services of a caterer that was providing meals for these patients at the cost of 1,600 naira per day. So at the end of the day, having that preparedness plan and having the public health emergency operations center, it really impacted on our response. Because if not for the plan and the presence of the PHEOC, maybe we might have had a larger outbreak on our hands. So I will just stress more on the importance of having plans. You have the cost to the health system in terms of medical treatment or outbreak control. Also, routine activities might get disrupted. Very important routine activities such as maybe routine immunization activities, they get paralyzed in the hospital. And like I earlier mentioned, healthcare worker infection can also lead to a drop in morale of health of staff. Then also earlier on, if I mentioned the issue of social distancing, whereby you may have a closure of schools, as we also saw during the monkeypox outbreak in some states in Nigeria. You also have a closure of transportation systems, decreased trades, which will lead to a reduction in foreign direct investments. So we have to understand that so many events, this period marks like the 100th anniversary of perhaps the deadliest epidemic in history, which has already been mentioned, which is the 1918 Spanish influenza outbreak, which killed about 50 million people. More recently, in 2003, we had SARS, which also affected about 8,000 people, costing about 50 billion US dollars. We also have swine flu, and also the 2015 MERS outbreak in South Korea that was imported from Saudi Arabia. It was it impacted them so much that it led to a reduction in consumer confidence in restaurants and other public health and other recreational activities in the country. So much so that the Bank of Korea had to decrease interest rates to a record low just to improve and encourage businesses. We'll also not forget the West Africa Ebola outbreak. Much has been mentioned about this during previous presentations. So these experiences highlight remarkable trends in infectious diseases today. Societal and economic impacts of outbreaks can be devastating. So what we can do, focusing now more on the subnational at the subnational level, is that we need to strengthen subnational EPR emergency preparedness and response. This must be a national policy priority. Already in Kebbi State, we have reactivated epidemic preparedness committees at both the state level and at the LGA levels. So this needs targeted legislative advocacy. Otherwise, our response to outbreaks will always be a reactive process rather than a strategic process. Then earlier on, someone also mentioned the issue of our integrated disease surveillance and response strategy. I think it was Debo. So I think we need to carry out routine assessments of this strategy using its core indicators of surveillance and response. Subnational levels must also have coordination mechanisms to respond better to disease outbreaks. So fortunately, the NCDC is taking the lead on this. They're rolling out public health EOCs nationwide. And really, we cannot overemphasize how that played a role in curtailing the outbreak, the Lassa fever outbreak in Kebbi State. Then also, the role of non-health sectors has also been mentioned by previous speakers. These non-health sector agencies have a profound impact on the prevention and response to outbreaks. In Kebbi State, immediately I go back within the next few days, we're already in the cholera season. So part of what we're doing to make sure that our plan, our preparedness and response plan is very adequate, is that we're going to have a one-day stakeholder meeting with the commissioners and permanent secretaries of ministries of water resources, environment, local government, all those agencies that usually have one or two stakes regarding cholera, just so to sensitize them on their roles, so that whenever they hear about cholera outbreaks, they realize that it is not only a health problem, but it's also a shared responsibility. Afterwards, we intend to come up with a joint plan which will be submitted for approval. So collaboration and partnerships is also very, very important. Like has earlier been mentioned, this will help to develop a robust human and animal surveillance. It can also be used as advocacy tools to policymakers. So my next point was something I earlier discussed. We need well-trained and equipped public health workforce at the subnational levels. Maybe the Honorable Commissioner may give us one or two insights on how we can achieve this. We're earlier talking about minimum requirements for appointments as local government DSNOs, state DSNOs, and state epidemiologists. Then I think we may have to also embrace the role of science towards understanding the local drivers of diseases in particular communities, because sometimes we tend to think it is a one cap fits all. So what may be applicable in a particular state may not be applicable to another state. So science may be able to help us facilitate preparedness in that regard. So finally, it's a very short presentation. Perhaps the most important call to action is for us as individuals to play our personal roles in improving epidemic preparedness and response activities, especially at the subnational level. So this is an incredible opportunity to be a part of that process, because I think the drive is there, but we all have to make sacrifices. Sometimes maybe, in fact, all the time we have to make personal sacrifices. And indeed, I think we are morally obliged to make these sacrifices. Thank you for listening to me.